I would like just to start. If the patients with a relapsed refractory lymphoma comes to your office, or if you just check the patients on the ward, so what's your algorithm? So what are the key questions or factors you take into account to make any decision, just to, let's say, to set up different scenarios? Because definitely we have a different scenarios for the first relapses, for different and for the subsequent. But let's say the first relapse.
Well, the first question typically we would ask is the timing of the relapse now with the approval of CAR T cells for patients relapsing within 12 months, because those patients would be typically candidate for commercial CAR T cells. Later relapses might be a candidate for some of the ongoing trials, but commercial use, you typically would follow the current approval pattern. And if the patients relapse more than 12 months later, then the question becomes, are they eligible for hematopoietic stem cell transplant, which we still use for those patients. Although I must say this population is relatively small, so it definitely created a dent in our transplant practice.
Yeah, thank you. And we can maybe to ask some other people who maybe do not have access to the CAR T cell, because this is the other factors that we have to take into account. So, but Judith,
so we don't have access to CAR T cell in Australia in the second line setting. So if the patient has early relapse, I would be giving the transplant eligible patient, RGDP and trying to take them to transplant. The transplant ineligible patient, I'd be giving RGMOX. But regardless of fitness to transplant, I would be imaging the patient very quickly after 2 cycles. I'd be trying to map out the tempo of their disease response, because I would be looking very carefully for any patient who really needed to transition to a third line approach, because then I can use CAR T cells. But at the same time, if the patients, particularly those who've got late relapses, if they're doing well on their IGDP, and, I have no hesitation of taking them to an autologous transplant.
Francesco, your...
Yeah, we don't have second-line CAR T approved or reimbursed yet, so it's going to be this year. So we are following a standard RGDP, autologous transplantation, or GMOX. Yeah.
Martin?
Well, I'm living in the paradise of North Central Europe, and therefore we have CAR T cells, and therefore what has been mentioned is for us crucial, which is the duration of first remission. However, on top of that, I think we always consider essentially 2 additional things. First of all, fitness of the patient still, and also the aim of the treatment. We all know that there are what I would now call intermediate aged people, let's say in the age of 70, 75 years, where we're going for CAR T cells, but there are also these 80, 85-year-old chaps, based on our demographic changes. And there the balance between, the aim and toxicity is different. And secondly, it's always about also the aggressiveness of the disease, how quickly you have to consider it, how aggressively you have to bridge patients. And definitely for me, myself, I'm a simple-minded doctor, so I always look at the LDH. LDH as a quantitative marker for me is more guiding than IPI itself.
Okay, thank you. Astrid?
Okay, so I'm also in a part of the world where we don't have CAR T, and we're not expecting them to have them very soon, but still I think time to relapse is it's the most important prognostic factor for relapse, or dividing between primary refractory patients or late relapse. The standard of care would still be salvage chemotherapy and autologous stem cell transplantation for suitable patients. And we had recently approved polatuzumab for Arbenda polatuzumab for patients who are ineligible for transplant or relapse after transplant. So maybe that's the newest option of therapy that we have, this triple combination.
Okay, Gilles?
Yeah, it's not surprising how the world is splitting according to access to care. I mean, I would say that when I see a patient with first-line DLBCL failing therapy, my question is he eligible for CAR T-cell? And why cannot do CAR T-cell? Because we have also the approval in second line for non-transplant eligible patients. So, I mean, for younger patient and late relapse, yes, I mean, standard of care will be salvage therapy followed by transplant. But for patient over 70s or with comorbidity or patients that I will not routinely consider for transplant, the question is, why is this patient not able to receive CAR T? And I think, you know, we have for 1BB CARs and available that are really here. So I think this is really a preferred option, and I have exactly the same question as Martin, which are basically how I'm going to manage this patient to bring him to CAR. But let's put it like that, things may change, and I think we probably will see combination of other drugs being efficacious in this setting, avoiding eventually the burdensome of CAR T for this patient. But right now, this is my main question for patients.
Okay, Uli, you are the last one who has the privilege to give the answer. No. Go ahead.
I mean, of course, we are a CAR T-cell center, and we have access to any type of treatment in any line that's approved. However, the problem we have is we don't get all the patients that we should get. So there are differences between hospitals, even in a rich country like Austria, and I'm sure the others experience that as well. So one of the questions we really have is, why do different levels or hospitals or who would have access not treat patients according to, let's say, the latest developments? Interested to hear what the others say.
Yeah, education takes a lot of time. You think that is right away, and it's time to educate physicians. And second, some of the physicians don't want to lift the patient to other centers, and this is happening as well.
I think there is an element of patient preference in this too. You have to remember it's a disease of the elderly, right? A lot of patients will be quite elderly, and when approached about the treatment, and unfortunately, you know, they're quite discouraged sometimes of the failure of initial therapy. So when the question comes up, a lot of those patients elect not to pursue any therapy or very minimal therapy closer to home. That's definitely a factor in the US, which affects the referral pattern and pursuing of the new therapies in this space.
I think there have been three factors that I've found have personally impeded access to CAR T. The first one is patient willingness to leave and go to another site. Secondly, our own availability of bispecifics, because many sites that didn't have CAR T cell access that had well-developed bispecific antibody studies, so we could offer that to a patient. And then often there's a frailer, older patient population. By the time they've had a bispecific and they've relapsed again, they're less willing to go around a third time. And certainly if it means being sent away from their treating institution. And then the other reality for us in Australia is to some extent access, and we've got a bit nervous about this when CAR T gets approved for myeloma, and then there's a tsunami of competing patients for the service. I think there's been a real, I suspect all around the world in many countries, there's been a lack of planning by jurisdictions for this.
I think that it has been clearly demonstrated that we have a different scenarios. The first question, definitely in current days, in those countries, the development line, are available if the patient is eligible, which consists of the, let's say, the time to relapse. So it means within a 12-month period, and then the fitness and some other factors. And for the situations where we do not have the access to the CAR T cells in the second line, we still have to use try to use the transplant or non-transplant approaches. And definitely, I think that the diffuse large B-cell lymphoma is moving to the category of the diseases when we have to think about the subsequent steps sometimes, because we can use something for the second line, and for those countries where only the CAR T cell in the third line, then we have to use, let's say, maybe not the bendamustine in the second line. But definitely it's challenging, and I definitely would like to ask Natasha if she can give us more time to discuss it the next time, because we really have chance to focus only on the one question, which is globally different as well. Thank you so much.